Thank you for the introduction. Thank you so much for having me here. It's really nice to be able to do this presentation. So I'm going to be presenting a case of psoriasis and depression. These are my disclosures. So the case is a 20-year-old male. He came in with a 1-year history of a rash affecting the scalp, trunk, extremities, and genitals. He noted pain in his hands that were worse in the morning. And so far, he had only been prescribed small tubes of topical steroids by the emergency department, which has not been helpful. And you ask him some questions about his skin condition, and he's just giving you really short answers, not super talkative. On examination, you notice first that he really is avoiding eye contact with you. He seems kind of antsy and not very comfortable at all. You ask him to show you his skin, and he's very hesitant. When he finally is open to showing his skin, you find that he has psoriasis, almost all over the body, on his scalp, trunk, extremities, genitals, nails. You look at his joints, you notice some dactylitis in his fingers. You calculate a PASI, and it's 15.3, which is quite severe, and his BSA is about 30% affected with psoriasis. So because his psoriasis is so severe and he just seems overall, very uncomfortable, anxious, you have him complete a couple of questionnaires. First, the DLQI, the Dermatology Life Quality Index, and that scores out to be 15, which is equal to a very large impact on quality of life. Then you have him do the PHQ-9, which measures depression. This is often used in the primary care setting, just 9 questions. And he scores 14, which is equal to moderate depression. And so going back to what Dr. Armstrong just highlighted for us, depression is seen in approximately 20% of patients with psoriasis. And suicidal ideation or behavior is seen in up to half of these patients. The majority of these patients do admit that their suicidal ideation or behavior is actually due to their psoriasis. And this is compared to only about 4% of the general population who have depression and suicidal ideation. So psoriasis patients are really at much higher risk of depression and suicide. And as Dr. Armstrong also stated, psoriasis patients are at 2 times greater risk of depression and suicidal ideation compared to the general population, and this is even after controlling for variables like sex, age, race, BMI, physical activity, history of smoking, alcohol use, and other major medical problems like history of heart disease, stroke, and diabetes. And so some of the risk factors for developing depression in patients with psoriasis include female gender, younger age, more severe psoriasis, symptoms like itching or pain, involvement of certain locations like palmoplantar psoriasis, genital psoriasis, nail psoriasis, and then also psoriatic arthritis. And so in our patient, he did have a lot of these risk factors. So he was a bit younger, his psoriasis was quite severe, he had genital and nail involvement, he had evidence of dactylitis, which is consistent with psoriatic arthritis. He wasn't very talkative, so he didn't tell us his symptoms, but I'm sure it was very uncomfortable for him. And so he had a lot of these risk factors for depression. And so, as we all know, it's a vicious circle. Stress can flare psoriasis. Psoriasis can impact quality of life in terms of, affecting social interactions, intimacy. It can affect work productivity. It can affect your mental health. That in turn causes more stress, and it just keeps going and going and going. And the key is that we have to break this cycle. And as Dr. Armstrong stated, there's definitely the systemic inflammation that's shared between psoriasis and depression. So these are some of the markers that are inflamed in depression. IL-17 was also another one, and IL-23 as well. And interestingly, treatment of depression will actually normalize these levels. And specifically looking at IL-6, IL-6 does play a key role in depression. This is just the surface of what Dr. Armstrong described, but IL-6 affects tryptophan metabolism, which is neurotoxic, and that can be seen in depression. IL-6 can also affect the HPA axis, and so hyperactivation of the HPA axis can be seen in depression. And if you look at the pathophysiology of psoriasis, IL-6 does play a role in terms of inhibiting regulatory T cells and also stimulating the Th17 pathway. And interestingly, it's not only psoriasis, but other systemic inflammatory conditions like cancer, heart disease, and RA also have IL-6 also plays a role in the pro-inflammatory effects of these conditions. And so going back to our case, this patient was started on risankizumab. We did offer a mental health referral for this patient, just given the PHQ score and such, but he declined at that time. We saw him back 4 months later, and he was actually making a lot more eye contact. He was more talkative. He was actually wearing a t-shirt and shorts and not a hoodie. His PASI was 1.7 with a significant improvement. BSA was only about 3%. DLQI at that point was 7, which is equal to small effect on quality of life. PHQ-9 was 2, which is equal to minimal depression, and no treatment is indicated for the depression. And so he had seen significant improvement in both his psoriasis and his depression symptoms. And so what can we say about this case? So treatment of psoriasis can improve depression symptoms, specific with biologic agents. Dr. Armstrong showed us a lot of data on that. And this is presumably due to, the improvement in quality of life, but also the improvement or decrease in the systemic inflammation that causes both psoriasis and depression. And the other studies also have shown that treating depression along with psoriasis in different ways, like through psychotherapy, cognitive behavioral therapy, relaxation training, that kind of thing, can definitely be beneficial to patients with psoriasis. So in addition to psoriasis treatment, also offering, referrals or treatment for the psychiatric comorbidities. And so the clinical recommendation overall is that you do want to screen patients for depression, especially if you identify some of the risk factors for depression. So, we mentioned female sex, younger age, more severe psoriasis, more severe symptoms, psoriatic arthritis, all those things. If you see a lot of these risk factors, you may consider screening patients for depression, if not everybody really. And you could also look at other comorbidities that are associated with systemic inflammation. So for example, cardiovascular disease, metabolic syndrome, diabetes. If there's just this overall systemic inflammation, may be good to see if depression is one of those things too that the patient is suffering from. As we've always said, you want to treat psoriasis patients adequately, especially with biologic therapy. You're seeing quick improvement in psoriasis and quick improvement in depression symptoms as well. Multidisciplinary care with mental health professionals, definitely helpful. And you want to reassess mental health status at subsequent visits. For example, if a patient's psoriasis has cleared, but they're still showing, high levels of depression, you may, consider mental health referral at that point. And there are some useful tools to use to screen for depression and suicide. So the Columbia Suicide Severity Rating Scale, I think a lot of us are familiar with. This is the one that's used a lot in clinical trials to assess their suicidal ideation and behavior. It's a questionnaire that's given by the provider to assess for suicide symptoms. That can be helpful. And then the PH2 and 9 are often used in the primary care setting to assess for depression. And this can be really quick and easy for the patient to fill out even in the waiting room. HADS is often used as well. The Hamilton Rating Scale for depression is like a very classic traditional one, not used as often anymore, but kind of the basis for more of the other depression scales that are out more recently. So in conclusion, depression is prevalent in psoriasis patients, and this could be due to psoriasis' negative impact on quality of life, but also due to systemic inflammation and shared inflammatory pathways in psoriasis and depression. Treatment of psoriasis can improve depression. Treatment of depression can improve systemic inflammation and stress associated with psoriasis. And so adequate treatment of psoriasis is key. We want to incorporate screening for depression and multidisciplinary care with mental health providers and patients with psoriasis when indicated. Thank you so much.